So, good morning, everyone.
Good morning.
Hope everyone can hear me well. I'm Martijn Cremers. I serve as the Dean of the Mendoza College of Business, and it's my great honor to say good morning and welcome all of you to the 2024 Diversity, Equity, and Inclusion Grow the Good in Business case competition. Before we get started, and really the main thing other than welcoming all of you that I need to do is to thank everyone who made this wonderful event possible. Very much starting with Professor Kristen Collett-Schmitt, our Associate Dean for Innovation and Inclusion here at Mendoza. Kristen first launched this case competition as a very important and really essential part of our continuing commitment to building a diverse, inclusive community here at Mendoza and more broadly, right, at the University of Notre Dame. The competition was excellent last year, as Kristen then expanded it to also include undergraduate students and MBA students, who are now all competing alongside the specialized master's students that originally got it started. So we very much look forward, all of you students, to your presentations, what you will bring us this year. Second, I'd like to thank Laura Bryan and Stephanie Drudge from our Experiential Learning team. They worked countless hours to also make this event a reality. Then, thank you to our sponsors, KPMG, First Source Bank, ADP, the South Bend Elkhart Regional Partnership, the Notre Dame Institute for Global Investing, and Beacon Health Foundation. Thank you very much. Without your support, this event could not happen. We're also very grateful to our strategic partners, the Fitzgerald Institute for Real Estate, Summa Health, the Deloitte Center for Ethical Leadership, the Fanning Center for Business Communication, Jiffy, the Lucy Family Institute, and Impact Assets Capital. Again, without your engagement and support, this event could not happen. Thank you also very, very much to the people who are sitting there on the sidelines on the back. All of our judges, thank you so much for your time, for your engagement, for your support. Thank you for being here and imparting your wisdom onto our students today. Last, and very much as probably the most important, I want to thank our students. Thank you for participating in this case competition. Thank you for your great enthusiasm, effort, and energy you have shown. That's not surprising. We're Notre Dame and we like a competition. But more than that, this competition reinforces the pursuit of equity as essential to good business and to our charge here at Mendoza to grow the good in business. And as I like to say, to grow the good in business in three ways. To grow as servant leaders who contribute to human flourishing, to cooperate with all stakeholders in solidarity and equity, and to compete to become the best version of ourselves by the grace of God and with the help of others. Now I'm pleased to turn the podium over to Kristen, who will tell you more about the competition and today's events. Please join me in giving a round of applause to Kristen Collett-Schmitt.
All right. Thank you, Dean Cremers. And it's a true pleasure to see you all gathered here today for our third annual case competition. Here in Mendoza, as Dean Cremers said, we believe that businesses play a pivotal role in working towards meaningful progress in creating inclusive workplaces and communities that flourish. As educators of future business leaders, Mendoza College of Business therefore has a responsibility to provide both formal and experiential learning opportunities like this case competition to demonstrate the value of creating an inclusive environment that promotes mutual advancement. As we all know, the opportunities and challenges in the DE&I space are complex and multifaceted. This annual case competition allows us to address many of those issues year after year as they evolve into the future. For this, our third year, the case focuses on the rise of private equity in healthcare and its role in addressing health equity. Today's event is a culmination of several months of case competition activity. After forming teams in February, students in Mendoza's undergraduate and graduate programs began developing their ideas. As they formulated their plans, students sought feedback and mentorship from faculty, sponsors, and health equity experts. We observed them using the business acumen developed here in Mendoza, as well as interdisciplinary skills from across the campus, and then showcasing their leadership, problem solving, and teamwork skills. It's really been an incredible journey for all of us, full of excitement, creativity, and definitely hard work. And I can definitely say we've seen some truly outstanding proposals. Today we are gathered to hear from the top 6 teams in the competition, 3 of which are representing the Notre Dame undergraduate program, and 3 teams are from Mendoza's various graduate programs. And I'm excited for you to meet them all very soon. And so if you'd like to follow along with our agenda today, please take a moment to scan the QR code here if you've not done so already, and that'll show you the way that our events today will unfold. On this final day of competition, I can personally say that I am incredibly proud to have the honor of working with every single one of our students, the faculty, staff, alumni, and the sponsors participating in this competition today. And to recognize all the individuals who were involved in this important initiative, please give a warm welcome to my colleague and good partner in bringing this event to fruition, Stephanie Drudge.
Thank you, Kristen. I can honestly say I'm so honored to be here today, and all of the work that we put together to be here with our final 6 teams. It's truly an honor, and I want to also express, as Dean Cremers and Kristen Collett-Schmitt said, welcome to all of you. If you're coming to us from the outside, from one of our sponsor organizations, we appreciate you and all of your effort to be here today. I'd like to take a moment to acknowledge all of the students who participated in the competition from round 1 to today, and then also those of you who partnered with us to help us get here to where we are today. So this is a list of all of our students who participated. It's a huge list. There were over, I think, almost 80 students participating, and I'll go through some of the numbers. Our department is loves numbers, but it is, I think, one of those that is kind of amazing to see how many students from year 1 to year 2 and now year 3 of the competition, to see how it's evolved over time. It's definitely launched for sure with all of Kristen's efforts. One of the things to note is this year with our students, we opened the team requirements to students outside of Mendoza, so that's a first for us. The first year it was specialized master's students. Year 2, we opened it up to undergrad and MBA, as Dean Cremers had mentioned, and then this year, 1 student had to be a Mendoza student, but then outside of that, it could have been anyone, any student at the University of Notre Dame. So you'll see when we go through some of those numbers what that represents. Our finalist teams have some firsts. So we have a student who's in one of our final top teams who is from a degree program outside of Mendoza. So that's a first. And it's our first opportunity to have executive students sitting with us with our executive MBA program. So we've got some firsts this year, and it's exciting. Also want to take a moment to acknowledge those who participated in our round 1 activities. So we had round 1 judges, coaches, and mentors. We instilled a first time 1 week one-on-one coaching and mentoring with the students, and they all took advantage of it. And I think most of you sitting here probably took advantage of meeting with someone during that time. So thank you for sharing your time and your expertise with the students to help them get here today. And then here's where our numbers are. So our office loves to see what all was put together to get to us today. So we had 79 students, 27 teams, and of those, 7 were from graduate programs and 20 undergraduate majors. And you can see the breadth of representation that we had in all of those 27 teams. We had 6 faculty coaches, 7 mentors, and then 23 first round of judges. And those numbers are absolutely amazing, exciting, and really truly why we're here today. So we're going to take a moment to recognize our judges, but I do want to take this time to now ask our undergraduate teams to depart with Kristen. and prepare to present. We will see you in just a moment. Thank you. And while they are getting mic'd up and ready to present, I want to take a moment for our judges to do a quick introduction as we work our way around the room and see who we have on our judges panel. And let's go ahead and start in the back, and we'll work our way up front. And then our teams will be in shortly.
Good morning, everyone. My name is Dr. Amanda McHenry. I'm faculty here in the Department of Management and Organization. I also have the privilege of directing our Planning Center for Business Communication, and I serve as the academic director for our undergraduate program. In my nearly 15 years here at the university, I've had the opportunity to coach thousands of students on presentations, and I'm looking forward to seeing a few more this morning. Thank you for being here.
Yeah, hi, good morning. My name is Daniel Wendell. I'm a senior analyst with Cambria Investors in Denver, Colorado, where I focus on primarily on healthcare and life science. And I'm a Notre Dame MBA grad, so I'm very happy to be back here on campus and talk about this.
Hi everyone, I'm Jim Sperduto. I'm the president of ADP Small Business Retirement and Insurance Services Group. So ADP, for those who don't know, we help over 1 million clients with payroll and HR and taxes and compliance and all that fun stuff. I've been with ADP for 30 years, actually 31 years, if you count my internship. And the internship that I got was because I had an awesome professor here at Notre Dame that during our junior year made us get summer internships with the hope of having an offer before we came back. So anyway, 30 years later, I'm still here with ADP, and we're honored to be sponsors of this event, and it's absolutely a privilege to be here as well as a judge. So nice to meet everyone.
Thanks everyone for having me as well. I hope to one day have that kind of tenure here at Notre Dame. I've been at the university for about 18 months now. I work in athletics as the Pat and Jane Eilers Associate Aide for Sports Performance. And today I'm probably representing a little bit of the call for the spirit of competition that the Dean referenced, but my role is to be the thread between all of our student athlete facing support areas, so sports medicine, strength conditioning, nutrition, psychology, so a lot of relevant subject matter today, but I'm excited to be here and learn from you all, so I appreciate you having me.
Hi, I'm Helena. I'm a senior at Notre Dame. I'm in the program of global studies, so this is me treading new waters in Mendoza. I'm the CEO of Jiffy, which is a nonprofit run by Notre Dame students. We provide small loans for Southland residents so they don't turn to predatory lenders. So thanks for having me.
Hi, good morning. My name is Jessica McManus-Warnell, and I'm on the teaching faculty in our management department. I teach MBAs and undergrads in ethics and sustainability. And I also have the fortune to serve as the faculty director of our Notre Dame Deloitte Center for Ethical Leadership. Our mission is to bridge academic research on ethical leadership with business and practice. So I hope that our friends in the audience will stop by our table today and learn a little bit about our center and how we might serve as a resource for you. I look forward to seeing the students' good work. Thank you.
Good morning. My name is Kimberly Green-Reeves. I'm currently the Executive Director of Community Impact for Beacon Health System. In short, we are making sure that there is preventative health and case management, disease prevention for all of our 4 major hospitals. We are currently in 4 counties in 2 states, including Upper Michigan. And so we're excited to be here. I am also currently an executive MBA student here at Notre Dame, class of 25. It's a pleasure to hear the students today and also a privilege to be a judge. Thank you for having me.
Good morning. My name is Holly McHugh, and I work for First Source Bank. First Source is one of the largest regional banks in the area. We provide support for small businesses and throughout the region. I
I work in human resources and the benefit management area, so I look forward to hearing what the students have to present on diversity, equity, inclusion, and healthcare.
Good morning, everyone. My name is Claudia Saran. You're going to hear probably more about me than you're going to care to know in the keynote, so I'll keep this brief. I was formerly our vice chair of culture at KPMG. We're about 40,000 people around the country, keeping us aligned with our values. You'll hear a little bit about that story too in a bit. But I currently corral all things industrial manufacturing for the firm. So our audit, tax, advisory clients in automotive and aerospace and defense. And really happy to be here. I'm so interested to hear the cases.
Good morning. My name is Drudge, and I'm a partner with KPMG, based in Chicago, former donor. I lead our reward services practice in the Midwest, so help our clients develop strategies around total rewards, health and benefits being a very key one, so very topical. As Claudia mentioned, DP&I is really close to our values at KPMG, so yeah, anytime you get a chance to come back to the university and be part of this discussion, we really can relish it, and just really looking forward to the event today. Thank you.
Thank you to our judges. So a sincere thank you to each of you. And as you can see, we've got a distinguished panel of folks from within the University of Notre Dame, alumni, and our community partners as well. So thank you. So it's now time for us to introduce our first undergrad top finalist team. To give you kind of a lay of the land with how this will work, they will present for about 8 minutes, no more than that, and then we'll have 4 minutes of Q&A from the judges. So you're welcome. We'll open the floor up, and then we'll transition to our next team. So I'm going to go ahead and let them know it's time for us to hand the floor over.
Hello and welcome. Today we propose to you MaternaLink, our investment opportunity to improve health equity by focusing on underserved women facing barriers to high-quality maternal health care. My name is Lundblad, and I'm a senior finance and physics major from Hilton Head Island, South Carolina.
And my name is Renee Maslak, and I'm a senior physics and medicine major and entrepreneurship minor from Saratoga Springs, New York.
Being women ourselves and speaking with our own mothers, professors, and friends, we have come to realize just how important high-quality maternal health care is to those throughout the pregnancy process, especially for those facing barriers to entry and systemic biases.
Furthermore, as a result of the one-child policy in China, I became an orphan. With MaternaLink, I strive to provide access to the support and services that all pregnant women deserve and the kind of care I wish my birth mother had. So the alarming statistics that we found surrounding the maternal health care crisis in the United States is ultimately what inspired and led us to design a solution to this problem. So in the circle diagram are some of the key issues that contribute to this crisis, and I'll be focusing specifically on maternal mortality rate and racial disparities. So despite significant advancements in medicine and technology over the last 20 years, the number of maternal deaths in the U.S. has nearly doubled, and our country's rate remains the highest among all developed and wealthy nations. Furthermore, Black women are disproportionately affected. As you can see in the graph, the rate of maternal mortality for Black women is nearly twice the rate of the national average and that of their white counterparts. And in this graph, you can also see the further disparities that affect all of these different races here in the U.S. And it further highlights the systemic issues and inequalities that mothers face.
Our solution is MaternaLink, an integrated virtual healthcare platform that uses telehealth services, existing community support, and financial and educational resources to support mothers as they go throughout the entire pregnancy process. What makes MaternaLink innovative is its ability to use these existing resources to create synergies and deliver high-quality care to patients. Furthermore, its inclusive and personalized approach creates a platform where women feel comfortable asking questions and raising concerns as they go through the prenatal, delivery, and postnatal process.
MaternaLink provides access to quality and timely telehealth services. With access to a variety of providers on the platform who are not only vetted and trained in diversity, equity, and inclusion practices, to foster the development of skills and knowledge surrounding cultural competency, cultural humility, and person-centered care. MaternaLink also offers women the ability to fill out a preferences survey when they sign up, and our system will then give them suggestions for various providers that match their preferences. Women are also able to apply filters and browse through numerous profiles of the variety of providers we offer, and so that they can find a provider that would be the best fit for them and that they would trust and feel comfortable with. The second feature that MaternaLink offers is the ability to connect women with the existing local community resources that offer services to pregnant women in the community. And as an example, we've included here on the right a handful of the organizations that are here in the South Bend, Mishawaka, and Elkhart communities that are available to all pregnant women. Furthermore, this platform connects women to other women on the platform to build community and to bond over the shared experience that is very special, and the experience of bringing a child into the world. Finally, our platform offers a variety of educational resources that not only educate but also empower women and their support systems. And this is notably seen through the educational materials here on the phone screen on the right, but also through the visual aids offered on the telehealth during their telehealth appointments. So they can see different illustrated processes and diagrams, which enhances communication and understanding.
So we created MaternaLink for all mothers and families, but where we really believe it can improve health equity is serving those underserved mothers who have barriers to access and lack of support and financial resources. So the resources we identified as being needed is partnerships with local communities in partnership with the secure technology platform we create to create synergies and drive cost savings throughout the broader healthcare system. As a result, all key stakeholders are satisfied, from mothers to providers to insurance payers, as well as investors. With an initial total startup cost of $48 million, we believe that we can turn MaternaLink from an idea into a reality, starting first with a local pilot program that will then grow and evolve into a nationwide operating platform. So who will pay for MaternaLink? In addition to the initial startup costs funded by nonprofits and foundations, as well as insurance reimbursements, we believe that we really want to show that the MaternaLink platform drives cost savings through the integrated approach and the synergies it brings.
So why does MaternaLink work? MaternaLink has a high potential for successful implementation and impact because of its alignment with all of its key stakeholders and its ability to scale. Like Eileen previously mentioned, MaternaLink not only benefits the patients, but all of its key stakeholders, and it does so through a reduction in costs and burden on the healthcare system and by increasing efficiencies within the broader healthcare services network, which creates an attractive return on investment for all. With nearly 4 million births in the U.S. annually, MaternaLink caters to our country's needs for quality maternal care. Furthermore, MaternaLink will innovate with each new user, enabling the platform to collect more data, refine its services, and improve user experience on the platform. And finally, we plan on marketing MaternaLink through the local women's clinics, the community organizations in which we partner with, and through other trusted leaders in the community, like religious institutions.
So finally, we want to hit on a few KPIs that are important for measuring success, including the total active users and the number of healthcare providers on the platform. We're also targeting a 90+ Net Promoter Score. That isn't just a number. We want to highlight all the things that go into this customer satisfaction metric, including increasing the amount of earlier detection of serious complications, as well as decreasing the amount of expensive emergency room visits.
Finally, tying MaternaLink back to Mendoza. MaternaLink will be a powerful means for good as it reflects the Mendoza College of Business's ethos of growing the good in business.
Thank you so much, and we'd like to open up to questions.
Thank you very much for the presentation. Very excited about the work. Agree with the data showing the disparities around infant mortality. question for you is you spoke about the connection with various stakeholders, including payers and providers, social service agencies, et cetera. Can you explain a little bit more about how exactly that connection would work?
Yeah, and that's something we kind of grappled with a lot because it's like dealing with insurance and government agencies, but we see like, we've kind of built this as a model for like compared to like other telehealth services, like the employer offers it as a part of their insurance benefit that they're like reimbursed for, and then that's part of like the same with like Medicaid. And in addition to that, like what we really want to emphasize, and hopefully that came through, is like the cost savings. We also have some like statistics on like kind of how it benefits everyone, and that kind of goes through with like how the reimbursement flow works. It's not only like reducing the burden on like the healthcare system, but women are able to get more like efficient care and then utilize these nonprofit resources that are so available to them in the communities. So it's cost savings for everyone, and that's why we really think it would be like a great investment. So it's satisfying all those key stakeholders. I hope that answered your question.
It does. Thank you.
Thank you, and it's great to see a former student out there. That's wonderful. But my question would be, could you talk a little bit about, part of the issue, of course, is that some communities are not engaged with the healthcare community and with the NGO community and others. How would you address this issue of getting your services to the people who need it?
So I think that of relying on some of the other trusted leaders in the community, specifically religious organizations, is what we found to be very trusted within these communities. And then through local clinics and services that are already that women are already using, pregnant women are already using, and also marketing it through organizations. And by marketing it through these organizations, we help reduce their marketing costs, as well as we help to add to their metrics in measuring their social impact, because we know it's so hard to measure that. So adding to those numbers for them, that we would be able to facilitate hopefully more funding for them in the future, so they can make a bigger impact within their community.
Thanks.
For the presentation. This is a super interesting topic. I was interested in terms of the vetting process of your vendors to make sure that not only do we get access, but access to high quality healthcare. How were you thinking about that process to get high quality supply of service meet this on that?
We were thinking we would do it through patient reviews. As when you look up a physician online, you can often find different reviews from patients. And we would also want references from other providers who are experts in their field and can help to vet them onto our platform. And then furthermore, being able to filter through all the providers based on whether or not they accept Medicaid, or if they accept private insurance, or if they work well with a certain race. That is also how we would help connect quality providers with women.
I'm going to make a note, this will be the last time for the last question. Dinesh will be next, and then we'll wrap up.
Super impressive, and I think this is a very topical conversation. Just curious, in terms of getting OBGYNs, I think it's a very specialized field. How do you tap into the network of doctors, which typically may sit into kind of hospital networks, to kind of enroll in kind of MaternaLink, which is really kind of a PE-backed initiative, which would be for profit?
We base this off of modeling it off of how the telehealth companies do so. So they're able actually to pay doctors more because of the cost efficiencies that it brings through. Instead of time spent waiting in the waiting room and going through the process of booking an appointment, as well as the overhead of running these. So these doctors are actually attracted to serve on these telehealth platforms because they're able to actually make more money, in addition to hopefully what we're using, the impact and mission to serve underprivileged mothers, and actually all mothers and families. So both of those, financial and impact related.
Thank you so much. Good job, ladies.
Alright, good morning everyone. Today we'll be proposing a solution which aims to tackle health disparities in rural communities, and this is through integrated hospital-tenant networks as well as advanced telehealth solutions. So our team consists of myself, Renee, and Mateo, all representing different colleges here at Notre Dame. So what exactly is the issue? Many rural communities in America are facing a crisis of lack of access to quality health care. And this can be depicted from this graph where we see the difference between mortality rates in rural areas versus urban areas. As you can see, over a 20-year period, we're seeing that the rates in rural areas are decreasing at a significantly lower rate than in urban areas. And this results in that major gap in 2019. So what exactly is causing these closures? Factors such as inadequate services, low patient volumes, and lack of healthcare physicians has resulted in over 130 hospitals closing since 2010, and even today, a significant number of rural hospitals are at risk of closure. So how is this affecting rural communities? Millions of Americans in rural communities are suffering from lack of access to what some would consider essential healthcare needs, such as hospital-based maternity care and psychiatrists.
So to solve this issue, we have a three-pronged approach, which includes a clinic-hospital network, where clinics refer patients to hospitals, thus increasing patient volumes with the referrals, which acts as a coupon rate for more specialized services. And clinics themselves also offer travel vouchers for travel cost barriers faced by many patients within rural communities. The second aspect is upgrading low-level centered hospital centers to trauma centers in an effort to increase capacity as well as increase patient volume through enhanced services. The last arm of our approach is an expansion of telehealth, which enables comfort and convenience for patients as well as reducing costs for hospital operations. Altogether, we have four major impacted stakeholders, that being patients, physicians, communities, and investors themselves.
To make sure this focused on DEI, we wanted to ensure that this was an accessible model by being able to provide access to those who are in remote locations and aren't able to physically come to the hospital through financial means or through physical transportation means. Additionally, we wanted this program to be multilingual, such that it could ensure that we are meeting all the languages in the local community so that everyone is seen and heard so they can properly access care. And this is further instituted through our receptive arm of this DEI approach, so that everyone knows the cultural and community practices in that surrounding area, so that they know some of the practices and underlying traditions such that could impact the health of their local community members. And this would further be extended through making sure that we have an affordable approach such that no one, regarded any, if they don't have insurance, if they aren't able to pay their premiums, they can still receive quality health care and live a happy, healthy lifestyle. So to implement this so that it is a profitable model, we would first acquire a low-level closing hospital that is on the verge of failure. And then we would revitalize it over 3 years and implement it into a level 1 or 2 trauma center, such that at year 4 it is profitable. And then while this is occurring, we would also be developing clinic partnerships within the surrounding community, such that they can refer patients who require higher levels of care to the trauma center. And while all this is occurring, we are also developing a telehealth platform from the ground up such that it is able to pilot within the first 3 years and then further extend to other rural communities in the surrounding areas and further reach our scope of practice.
In terms of the feasibility, as many of us know, the COVID-19 pandemic has significantly increased the use of telehealth within the United States. Even today, we're seeing around 30% of all hospital and clinic visits are already being conducted through telehealth. And the CDC is already investing in these initiatives within rural areas, so we believe that that existing foundation of telehealth in rural areas indicates success of further expansion of telehealth. And then on the trauma center side, we propose a model which allows hospitals to partner with private insurance companies based on the achievement of health outcomes, and this could be things such as low readmission rates and the like. And this would encourage hospitals to both reduce costs as well as optimize healthcare simultaneously. and profit share from some of these safe costs, which can be directly attributed to these better health outcomes. And then last but not least, many existing models already exist within the community health forum, and we would like to build and implement on some of these models. Things such as the better beneficiary and the beneficiary building funding models, and use these to incorporate things such as investments, donors, and government fundings into our model.
So the initial capital investment can range from 45 to 80 million, dependent upon the type of hospital renovations required, and we project a 5 to 7% profit margin annually.
Financial success would have hospitals experience nearly $21,000 in yearly savings as a result of telehealth, and patients themselves would experience close to $150 to $190 in savings for their visits. Further performance indicators involve quality of care and improved health outcomes, which can be determined by having patient satisfaction surveys to determine improved wait times and more efficient diagnosis, as well as tracing medical records and admission rates to determine lower infection rates, lower admission rates, as said earlier, and increased life expectancy. Future implications may require AI usage to further in telehealth or hospital administration in order to make tasks more efficient and streamline patient monitoring, and as well as hospital additions in local communities and surrounding locales may enhance profitability and allow for extensive outreach for patients. So what's the difference? Well, current solutions lack the operational efficacy and impact that our solution provides, such as that our solution enables by reducing hospital costs, increasing hospital savings, and increasing patient volume, which all ultimately increases revenue and profit. And this model can be scaled around to other hospitals across America as well.
So the investors are being stewards of Catholic social teaching such that they're trying to make a social impact in the surrounding communities. We're seeing them being justice for health equity, for trying to protect and provide for those communities and uplift them so that they are overall an empowered and healthy and well-being community, such that they can grow and prosper and further improve the overall community, business and culture and development. So thank you so much. We really appreciate all your support, and special thank you to Randy, our mentor, and we will move forward to questions.
Hi everyone, thank you so much for that. Very educational. A question around your timeline slide, sort of the implementation plan, and maybe probing a little bit on that proverbial quick wins. I know we talked about maybe the 3-year plus timeline for hospital transformation, but could you speak a little bit to, you know, if you're a citizen in one of these rural communities, what might be some immediate impact or immediate benefit that you would see in this program? Or do we indeed need to wait a few years?
Yeah, so the immediate impact will happen once we acquire the hospital. The hospital will still be operational, and citizens can still get the clinical referral and go to that hospital and use their coupon to get higher orders of care. We're just going to be able, after the transformation has occurred, they're going to be able to be fully able to get like all the specialized care. So the hospital might not be, you know, as specialized for neurosurgery at that point in time, but if they still need, you know, dermatology or something like that, that could be applied in the hospital currently when it is acquired, that is going to be continually ongoing during the transformational process. And those will utilize the coupons from the clinic partnerships if they don't have insurance to supplement the costs.
First of all, excellent job, and thank you for sharing all of that. To pull off this level of integration, it's going to require a pretty sophisticated data infrastructure, and a lot of hospital systems don't necessarily use the same electronic health record system, and especially with the acquisition piece. How do you envision navigating that or providing resources up front to help kind of streamline some of the potential concerns there?
Yeah, with the health records, you know, a large proponent is utilized through Epic, and I think we would try to integrate with the clinic partnerships such that the transfer from the clinic side can go to the hospital, and it's a seamless transfer so that, we're not playing catch up once we get to the trauma center, right? And I think to mitigate that is as we make our partnerships, we target first the ones that are utilizing the same medical health record platform. And, after we build an established network in our community, then we can branch off to, more of the other programs. But for ease of transition, that would be our first approach.
Okay, thank you.
All right, we have time for one more question.
Can you talk just a bit more about the motivations or important incentives that the clinics would need to consider before becoming a partner?
I think the incentivization for the clinics is that they will not be trying to reach out of their scope of practice. It will allow them to utilize their resources. These clinics are governmentally funded, they're also have state grants, and we don't want to overutilize their resources. So it'll allow them to, let's say this patient comes in, they need a shot, or they just need a cast for a broken arm. All the clinics can do that. We don't want them to try to over leverage their utilization and try to solve someone who needs surgery, or it's out of their scope of practice and they don't want to be in those types of lawsuits if something does happen. So that's a high incentive for them, and it will also further their reach in the community by allowing those resources to be available. Additionally, we will further be recruiting and establishing their patient bases as they know, like, oh, this is my way to get proper health care. This works for me and my family. This is good for my community. So that will really establish a good, strong connection between the clinic to the trauma center and make it everlasting throughout that community.
I guess to add to that, so with the travel vouchers, we hope that patients who may suffer from transportation barriers come to the clinics and increase that flow of patients and attendants, and then be referred, which ultimately increases the clinic's patient volumes and their revenues as well at the end of the term.
Very good. Thank you very much. Thank you very much. We're going to transition to our third undergrad team, and then we'll take a short break. Welcome. I'm going to hand this over, and you can start when you're ready.
Have you ever thought about your waste after you throw it away? What if we told you that the waste you don't think twice about could be the solution to health inequity in America?
We're going to be showing you how to turn waste into wellness.
For your community, for your health, and for your pockets. Hi, great morning. My name is Bernice Antoine.
I'm Alnagar.
I'm Remy Finn. And I'm Luzolo, Mateo.
And today we're representing a problem that exists in the healthcare industry. Health disparities are driven by social and economic inequities. Here are the 6 determinants: economic stability, education, community safety and social context, neighborhood and physical environment, food, and the healthcare system. We understand that there has been a concern of private equity firms acquiring hospitals and diminishing the quality of care that patients have. However, we recognize that private equity firms can be a solution. We offer a solution that gives them a way to maximize their profits as well as provide quality care for patients. Here's how.
To give a brief overview of our recommendation, first we want to acquire EcoHealth, a waste management company. EcoHealth will divide hospital waste into 3 categories: food, recyclable, and non-recyclable. From there, one option is for the waste to be turned into fertilizer for a community garden, helping to address food insecurity in underprivileged communities. Another option is for the waste to be converted into energy for the hospital, allowing these expensive medical bills to be driven down. And our solution focuses on 4 determinants: economic stability, food, community, and education.
Here's how it works. EcoHealth, the waste management firm that the private equity firm will be acquiring, is collecting 3 types of food from the hospital: food, recyclable waste, and non-recyclable waste. Here's what we plan to do with our food waste. We're collecting food scraps, baked apple peels, or banana skins, and we're turning it into compost. This compost will then be given to the community garden to ensure that persons have access to reliable food. Next, food rescue. Think about excess food.
For example, we bought too many burgers and we don't know what to do with them. We'll be taking this good, unused food and diverting it to communities that are food insecure. The food that is left over that is spoiled and is unfit for human consumption will be turning into fertilizer. This fertilizer will be used in the community gardens, again, to grow healthy food and assure equitable food access. We have a green thumb, so like all the companies, we're recycling our waste and putting it into recycling centers. But here is where we plan to make the big bucks, our non-recyclable waste. We'll be collecting these non-recyclable waste and converting it into energy. How? A process known as gasification.
What do these three processes have in common? They keep waste out of landfills. Why is that so important? 75%. That's how much more likely Black Americans are to live near a waste-producing facility or within fence-line communities than any other race. This is problematic because due to zoning laws and socioeconomic status, marginalized communities are being exposed to toxins and facing the challenges of the environmental crisis more than other groups. While policy can certainly address this, we also want to just minimize how much waste is going to the landfill in the first place. One of the ways we're doing this, as Bernice mentioned, is through addressing food waste. We have a food digester. Other than salvaging food that can be given to communities that are struggling with food insecurity, we can also use a food digester to simply minimize how much methane is being released through these landfills. Food digesters can be installed directly in the hospital's kitchen, and the two byproducts are gray water and fertilizer. The fertilizer can go to the community garden, and the gray water can simply go down the drain. This process happens within 24 hours. Furthermore, data is uploaded to the cloud so the kitchen staff can see which meals are producing more waste than others. Thus, they can save on the price of the foods that they're buying because it reduces waste, and therefore keeping more waste out of the landfills.
51%. This is the percentage of Americans that are struggling currently to pay their medical bills. But we have a solution for them. Gasification, waste energy through acquisition of EcoHealth. We understand that hospitals need approximately 2,000 kilowatts per hour of energy to operate daily. They also produce 2.475 tons of energy tons of waste every single day. Through our gasification process, 1 ton of garbage is equal to 1,000 kilowatts per hour of energy. When we multiply that, what do we have? Money. 2.475 multiplied by 1,000 is equal to 2,745 kilowatts of energy. This will allow us to reduce the cost that hospitals are paying to acquire energy. By reducing costs, they have cost savings. Cost savings means profit maximization. They could then transfer this cost savings to the medical bills. This means they're charging less for patients from marginalized communities for the medical bills. This is directly related to our economic stability, a determinant of health inequity.
The fertilizer produced through the compost, gasification, and biodigesting will be given directly to the community garden, allowing it to further flourish as a community space. Furthermore, this sponsorship through the firm will allow for more educational programs within the community, which teach the importance of healthy eating and gardening practices. And lastly, the community garden will be producing food for this community, which can address food insecurity and food desert issues.
We've divided our feasibility into our challenges and our metrics of success. The first challenge is efficient processing to ensure comprehensive integration of this new model. The next is technology adaptation in order to ensure that the hospitals are able to learn how to operate this new technology. And lastly, community outreach and participation in order to ensure that the community is on board, is aware that this is happening, and are choosing and willing to participate in this program. Our metrics of success are the social impact, which will increase production, visitation, and in the community gardens, as well as serving more members of in the community of various backgrounds. Next is environmental, in order to use more renewable resources, as well as have less pollution. Next is financial, in order to reduce the cost of energy, fertilizer, and patient care. And lastly, scalability, in order to have a replicable model that can be applied elsewhere and expanded. And now, what do the stakeholders gain from this? The first stakeholder, the community, has an improved health equity. The hospital is more sustainably used, and private equity firms still produce profit, have an improved public image, and also improve their ESG ratings.
Through the acquisition of EcoHealth and its positive impact on both hospitals and community gardens, we are creating a cyclical model between hospitals, community gardens, and the renewable energy sector, a model that currently does not exist in the healthcare system. Not only are we building a new model, but we are also redefining the way that we view waste. What was once shoved aside to landfills will now be used to create positive long-term health benefits for communities that have historically been harmed by the effects of landfills. Growing the good in business means addressing the needs of all communities, and we firmly believe that EcoHealth will move us towards this vision. Thank you.
Any questions?
Thank you very much for your presentation this morning, EcoHealth. It is very fascinating. There's a lot to it, and just wondered, have you given thought to where you would start should this come to fruition?
We could definitely take this question. So we plan to start with the acquisition of EcoHealth, which is a waste management company. But as a private equity firm, we want to understand that we are outsider coming into communities, which is why it's so important for us to establish that partnership with communities, and we're not like changing that power dynamic in that way. So first, we'll start definitely with that partnership with the community, ensuring that we build that mutual trust over time. And while that's just going on, and we're building that mutual trust, we're going to be in the process of acquisition and firm. We understand based on research that acquisition takes 6 months to 1 year. And so during that time period, we'll be working alongside with the community firm, understanding the needs of the community, understanding important stakeholders.
And also, sorry, just to add on top of that, we would ideally start with just one hospital, but then we could ultimately branch out to multiple so that we're producing more energy from more waste, or even just other industries that are also producing waste in the area.
Thank you.
Thank you. Fascinating presentation. I'm just curious, what is the expected cost to implement the gasification system? So for like a year one setup cost, including ongoing administration, and how long do you think it will take before you get the ROI?
That's definitely an important consideration that we took into. So currently, the input for gasification is about $1 million. We see that having that is a very high upfront cost, but based on research conducted, based on documentaries that we viewed, we see it evening out about within 2 years. And we also see the potential for other companies even giving us their waste, so it'll be able to shorten the time for the time period that we see the RI. But currently just taking waste from our company along, we just see it breaking that RI about 2 years, but that's a really important consideration.
And also with the biodigester, it's just under $1,000, and it's estimated that you can save upwards of $8,000 per year with not having landfill transportation costs, so it would pay itself back really quickly, and there's very low maintenance for biodigester as well.
This is great. I'm curious about the benchmarking you did of programs that might serve as a model. I know on our campus we have a food to energy process technology. What did you do in the form of benchmarking? And could you tell us a little bit about where you got those numbers?
Sure, no problem. So we did have an updated presentation which had the source, but we would have received it from Biomedical Health, as well as, I believe the second source I received it from was, if I remember correctly, Variable Health, but we could definitely follow up after the presentation and link directly to the sources, because we understand we want to build a reliable company here, so we need to be using accurate figures. To your first question, it was really important that we took into consideration the existing models of gasification. So currently there's incineration, but with incineration is where you burn the energy to get the fuel, but they have other negative carbon effects, for example, releasing carbon dioxide into the air, which again is a greenhouse gas. And we also looked at the grind to energy program that we have on campus, and we saw this more fitting compared to the hazardous waste that is also produced by hospitals that can be used by the grind to energy system. So we saw gasification as the correct method to go with. And of course, we are looking at different community health, for example, our very own community gardens. So we do also consider the community impact of it. Well.
Yeah, and for like specific hospitals, we look to Runnymede Hospital in Toronto for some of the biodigesting things to see kind of how it's functioned for them, and that's where we get those numbers as well, to see how they just implement it directly into their kitchen.
All right, it's actually time to wrap. Wonderful questions, great job to the team. Let's go ahead and give a round of applause to both this team and all of our undergraduate teams. Thank you very much. Wonderful job, ladies. We're going to go ahead and take a 5-minute break, returning at 11:10, and we'll transition to our graduate teams. So for the teams that are on our top 3 graduate teams, if you could, when we come back at 11:10, stay out in the hallway, and then we'll call you in one at a time. Thank you, everyone. All right, welcome back. We are eagerly awaiting the start of our graduate top 3 teams presenting, and I'm going to go ahead and cue up the slides of our first graduate team, and we'll go ahead and get started. All right, you can start whenever you're ready.
Good morning. I'm Anne-Marie from India.
Kingsley from Nigeria.
Fabrice from Burundi.
Any of us entering a healthcare system places immense trust in the hands of the healthcare practitioners and the administrators. Sunkida Rashid and her husband Nabil Haq placed the same amount of trust in the hands of the healthcare practitioners in the Stewart Hospital where she was admitted for her first delivery. However, their dreams were short-lived. Sunkida developed a bleeding in her liver, which led to the requirement of a medical device called embellished coil. However, this was not available in the Stewart Hospital, leading to her death. We talk about the efficiencies that private equity has brought into the healthcare system, but is it all encompassing? Where is the accountability? Data shows that 25% increase has happened in hospital-related complications in private equity-owned health facilities, a 27% hike in falls that has resulted, and 38% more bloodstream-related infections. So again, where would be the accountability? Let's understand private equity a little further. There has been a whopping $1 trillion investment in private equity in healthcare in the last decade, and this has been disproportionately in the case of specialty care because that's where there is more ability to profiteer, thus leaving behind preventive healthcare. And the areas of investment are dubbed as cradle to grave, which is again all encompassing. But private equity is definitely not without its advantages. There has been quicker access for patients and also improved access. There has been limited regulations for private equity as a tool to enter this sector, and also large capital investments. But still, we lingered around the aspect of preventive healthcare and why private equity is not doing its magic in preventive healthcare. And our concerns were confirmed through our conversation with Dr. Asha Shahjahan from Detroit, who is a primary healthcare physician. She asked us this question: wouldn't it be better for health and well-being of our country if we could prevent that deadly cancer than provide innovative chemotherapy? Upstream healthcare requires investment in primary prevention and inclusion of diverse populations. Only then can we begin to heal our broken healthcare systems. We present to you EquityCare to address the social determinant of healthcare access and quality, and also to recognize the need to derive social responsibility in healthcare investing.
Our model leverages the existing PE firms model with a disruption. Now, traditional PE firms always come together made up of general partners to source of funds from various organizations. Out of the 30% equity that they get, 2% comes from the general partners and 28% comes from institutional investors. But the rest of the 70%, they get that as a loan. Lenders like banks give them the money. What do they do at the end of the day? They acquire specialty hospitals. See what happens at the end of the day. Because they have a huge 70% loan from banks, they are pressurized to be able to repay that loan over a period of time. And that leads them to be able to increase the cost of their healthcare services. And when that happens, individuals who are of low income class are not able to access their healthcare provisions. The question then becomes, where then is equity in the healthcare system? So our model proposes that we want to replace the lenders, the banks, with two different groups, social impact investors and for-profit investors, on a scale of 50% and 20% to measure up to mark up the 70%. With this, the PE firms will be able to broaden into two horizons their investment in the healthcare system. 30% goes to PCP, primary care physicians, and then 70% to the the specialty hospitals. In this case, there is a balance within the system. For the PCPs, those who are of low income level are able to access the hospital, the systems, and have accessibility to healthcare. And those who are of the elite group are able to also continue to leverage the hospitality that they provide. Now, at the end of the day, you see that these PE firms continue to make their money from 3 different sources: annual management fees from the capital raised, monitoring fees from the institutional investors, and 2% after hurdle. At the end of the day, the system is not destroyed, the system is not stopped, but it's diversified to make things better for the PE firms and also to create equity within the system. Then, at the end of 3 to 7 years, this whole contract can be sold out. We have also confirmed that this model can work because in 2021, WCAS, Social Finance, and African Health and Atrium Health came together to demonstrate this in North Carolina, providing accessibility to different people. Then our pilot phase is going to be in Georgia, where Fulcrum and Social Finance will come together to launch this model that we are proposing, specializing on Summit as a specialty hospital and Northeast Georgia Group as a low PCP level. With this, we'll be able to broaden accessibility to everyone. The question now is why Georgia? Because Georgia, according to Forbes, is the worst state in the United States that when it comes to healthcare systems. 12.6% of their residents do not have access to insurance. And at the end of the day, we try to achieve that over 700 physicians will be utilized in terms of their skills and paid handsomely, and will be able to serve over 1 million people within the north side of Georgia. And then this is like a timeline that we propose in the next 1 year to be able to pilot that affair.
We are very cognizant that our program should be ethical as much as possible, which is why we are tying together a impact multiple money for social investors so that they could scale the quality of healthcare and so that they could scale the quality of healthcare against the private equity profit that has been scaled for the past years. And then our key performance indicators include that first, that we should be able to scale that the staff and the patient should be able to interact easily, and with provision of cultural competencies, providing language which should help the patient and the nurses to interact easily. And we are also recognizing that with the merging of private impact investors together with private equity, there could be a check of balance to ensure accountability of supply, and so that our model should run with scale which is guided by impact, not necessarily by profit that's been motivated by private equity. And in our imaginary situation, we imagine that with our model, a case like Sundaya, she would have admitted one of our healthcare, and then she would deliver a baby. After complication, we ensure that there is supply of material, which the private investors, together with private equity, ensure the accountability of the hospital. And then we imagine that on the 4th stage, Sundaya would have gotten a surgery and maybe get a 2-day break before she's able to join her family. We want that our model should put impact over profit, but at the same time, that's why we are proposing private investors together with private equity to come together to make healthcare sustainable. Thank you.
Great presentation. Just a question. So you're looking at kind of private investors to kind of back the PE firms from a lending perspective. Assuming that it's going to be a competitive bid for whatever hospital, and you've got another PE firm coming in with a traditional financial institutions lender, what is the competitive play and timing in terms of getting these funds from these kind of social economic investors, so to speak? And would it be a barrier from a competitive acquisition perspective?
Can you take that again?
Yeah, so effectively, if you are looking at a competitive bid for a hospital and you have your group, that's effectively the PE firm that's getting funds from, your kind of socio investors, versus a competing firm that's getting from a traditional lender, would that be timing constraints, ability to raise funds that could hinder the ability for you all to close the deal?
So to be sure that we got the question correctly, so the question is focused on the timing to access the funds. The timing to get the funds from either traditional lenders or private social impact investors. So the time difference. Okay, so traditional, ideally the way the system works is relatively easier to get funds from existing lenders in terms of this type of business, but we are not thinking short term. We are thinking about long term. So if you consider short term to go quickly to get the funds, then what happens after that? What's the effect of utilizing the loan? Because the loans you take don't even appear in the PE firm's balance sheet. It goes to the hospitals, and that also mounts pressure on those people. So we are ready to take back a little to delay the process, not relatively so long, but to get the funds from where we will not be under pressure to pay loan. And when we are not under pressure to pay loan, the cost of healthcare services will be moderate and creating equity within the system. But if we go for loan, then that means we want to go for profit primarily and then disconnect the equity within the system. So we go for long term. So the time difference doesn't really impact our model because we are looking at long term.
To add on, I would say that currently we are seeing a growing number of social investors who are interested to intervene with private equity-owned institutions so that they could help to deliver the process that deliver impact to the population. So with this growing number of social investors which are doing, so this is one of we are going to take advantage of them and then introduce them to private equities so that they could help the health system.
Do you mind if I add another thought on that? So in recent time, in our research, we found out that most populations in the United States are questioning the quality services provided by healthcare systems owned by PE firms. So with the presence of social impact investors who already have a good reputation with the population, with the public, that will cushion that effect to be able to balance the system relatively, creating a good balance and equity within the system.
Yeah, great presentation. Thank you. I'm curious. You're going to compete with quite motivated capital. Is there a way where you can incentivize a behavior to return potentially a different return stream or a better return stream further out in time? Because essentially, if for non-profit or impact investors may be more limited than the motivated for-profit investors, is there a way to align the incentives where the return stream may come a little later other than a traditional IPO?
Sure. So we are seeing returns for social impact investors in two ways. So they have their traditional SROI, which would be measured in terms of the impact measures of money, which they would be receiving at the rate of $2.50 for every $1 invested. So we are ensuring definite profit for all of the investment, the monetary investment that they put in, but they also demand improvements in the healthcare system in terms of including DEI and also in terms of access for diverse populations, like the case that we discussed, the couple being from Bangladesh and probably requiring language services, and all of these aspects to be necessarily involved in the key performance indicators, which would also be measured as their returns in addition to the monetary profits that the impact investors would receive. So it's dual profits for impact investors while retaining all of the fees and the management fees and all of that for the PE firm, and also ensuring the profit percentage for the investors at the traditional rates. So we see these to be a mutually agreeable form of incentivization that we have built into this model called EquityCare.
All right, we are at time. Great job to our first team. We're going to take just a minute to transition.
Hi, I'm Katie.
I'm Hannah.
And I'm Caitlin. My M&A colleagues and I are so excited to talk to you today about Easy Plate, an innovative use of private equity to address health disparities resulting from food insecurity.
So, what is health equity? Health equity is when everyone has the opportunity to attain their highest level of health. We know that those of a lower socioeconomic status face more barriers to health equity, one of which is food insecurity, which is when an individual does not know where their next meal will come from or has limited access to healthy food. The CDC tells us that those who are food insecure spend 45% more on medical costs because they are more susceptible to chronic diseases, for example, obesity or diabetes. Now, we know that there is a lot more to food insecurity than just the food on the table. Some of these behind me explain that those who live in food deserts and food swamps might be more susceptible or facing limited literacy and limited access to transportation. Further, we know that food insecurity does not affect communities equally. Those who are Black, Hispanic, formerly incarcerated, lower income, women, and people with disabilities are more susceptible to food insecurity. These individuals turn to the Supplemental Nutrition Assistance Program, also known as SNAP and formerly known as food stamps. The USDA tells us that $107 billion annually is given to SNAP beneficiaries, which equates to 42 million people each year, averaging $211 per month per individual in SNAP benefits. Now, SNAP users still face barriers to access healthy foods, some of which include time to shop for foods for a healthy diet, limited knowledge about healthy eating, and limited time to cook. Now, I'd like you all to imagine that you're a single mother or father with 3 children and working a full-time job and are a SNAP user. You will still face many barriers like these, and because of this, you have 2 options for accessing food. The first is to take a 30-minute bus ride to your nearest Walmart, or to go to your local convenience store gas station. The USDA tells us that 20% of SNAP users use their SNAP benefits for unhealthy foods like these on the table: sugar-sweetened beverages, prepackaged desserts, or prepackaged meals.
So what if we brought the cultural foods that people love to their doorstep? What if we brought dignity and choice to SNAP users and made feeding your family healthy food both easy and affordable? At EasyPlate, we believe that everyone deserves access to affordable, nutritious, and culturally attuned food. EasyPlate is thinking outside the box to address inequities in healthy food access among beneficiaries of the Supplemental Nutrition Assistance Program. Compared to their competitors, we know that competitors such as HelloFresh often have meals that are pretty unaffordable and inaccessible to SNAP users. Meals often cost around $10 per serving, take many kitchen utensils to prepare, and can take up to 45 minutes to cook. Further, there are currently no meal kit delivery services that accept SNAP benefits. At EasyPlate, we are seeking to provide affordable meals to SNAP beneficiaries. Each of our meals costs $4.99, can be made with limited kitchen utensils, and take 15 minutes or less to prepare. Further, our meal kits are SNAP benefit eligible. This is a complete cost breakdown for each of our meals. It'll cost us $3.99 to produce each meal. We'll supplement our marketing and advertising costs through partnerships with local nonprofits who interact with SNAP beneficiaries on a day-to-day basis to get the word out and help people register for our program. Our markup is $1 per box, or 20%, a modest amount compared to our competitors. Customers can order EasyPlate meal kits such as these on our online platform based off cultural cuisine preference and household size. All of our meal kits are tailored through a combination of guidance from nutrition experts and community member lived experiences through our Community Member Advisory Council. Each EasyPlate dinner box comes with meal kit cards that give recipe ideas with a QR code linked to demonstration videos to give people ideas about what they can cook with what's inside their box. Further, our EasyPlate website and all accompanying materials are available in multiple languages and can be read at a 5th grade reading level or below.
Now let's talk about our recipe for success. The EasyPlate pilot, which is an initial $3.5 million investment, will be funded jointly by a foundation and a private equity firm, along with some debt financing. The foundation will use their program-related investment capability to provide what is essentially an interest-free loan for a portion of the pilot program. This partnership with private equity will give the foundation access to expertise and capital to fund a large-scale project they would otherwise be unable to undertake. For the private equity firm, they will provide the rest of the investment but will receive all of the financial returns, making otherwise moderate returns seem very high. The private equity firm investment is also significantly de-risked because we propose the foundation would guarantee a portion of the private equity investment and take the first loss on the investment.
We propose that we use our $3.5 million startup costs to pilot our program in the state of Michigan, with specific focus on the Detroit metro area, which we know from the USDA over 30% of households utilize SNAP benefits. Over a 3-year pilot period, we hope to scale up to capture 1, 2, and then 3% of all SNAP benefits within the state of Michigan, which equates to reaching over 40,000 households. We know that given the size of the SNAP market and the growth of the meal kit industry, an additional investment is needed to scale up our project nationwide. We anticipate over a 6-year period, 3 years in a pilot phase, 3 years of scaling nationwide, EasyPlate will experience growth in revenue and be able to increase their net profit margin due to scalability. At the end of this 6-year period, we hope to capture 1% of all SNAP benefits nationwide, which equates to $950 million.
We will use several metrics to assess the impact of EasyPlate. Within our first 6 years of operation, we hope to deliver over 350 million meals to families across the country, focusing specifically on areas affected by food deserts and food swamps. We also hope that through our intervention, there will be an increase in utilization of SNAP benefits on healthy foods as opposed to unhealthy foods among our customers. To assess the health outcomes associated with our pilot program, we would partner with the University of Michigan to run a research study. EasyPlate is an ethical use of private equity. In traditional PE investments in healthcare, there is information asymmetry present, and customers often don't have much choice over the care that they receive. Unfortunately, PE firms tend to prioritize financial returns over patient care, which leads to poor outcomes. With EasyPlate, the offering is accessible and the process is transparent. We've aligned financial and social goals, which is how EasyPlate grows the good in business. With each box sold, we're eliminating barriers to healthy food access and giving individuals the opportunity to attain their highest level of health. We invite you to join us in making the healthy choice the easy choice with EasyPlate. Thanks so much for listening, and we look forward to answering your questions.
Thank you all for the presentation. You touched on it just a bit, but I'm hoping we can hear a little bit more about the awareness building or the marketing to your target market, maybe just if you want to focus on that Michigan pilot, but if you could say a little bit more about how you get the word out.
Yeah, I'll let Caitlin answer this one.
Absolutely. So as we mentioned, we would have a network of partnerships to build trust with the users that we're attempting to market our product to. So there's several nonprofits in specifically the Detroit area, but also all throughout Michigan, that might interact with SNAP users on a day-to-day basis. So those would be the partners that we would gain access to and build trust, so that our offering makes sense to users and we can really get the word out there. And as Hannah mentioned, the community advisory board would be really important to us. So not only building trust through that, but improving our product and getting customers' input and insight into what they need for their boxes.
Great job, guys. Just a question. So you talked about your margins. I mean, it seems to be a huge market and a great opportunity, even if it's a few of the states. When we look at the gross margin profile, seems to be around 80% or so. Mm-hmm. What scale do you need to get to be profitable on the bottom line?
Yeah. So we base our margins, we're hoping to increase. In the first year, we think our net profit margin will be a little bit lower, but due to scalability, we hope to be able to increase from a 10% markup to a 20% markup ultimately. And we think we're going to be able to keep, we're trying to keep a modest markup just to make this product more affordable to our users, but we think we'll be able to keep our costs low in the per meal basis, just because we know that competitors like HelloFresh offer a hyper personalized option where you get to individually pick each meal. Our boxes would be a little bit different in that you're actually just selecting a cultural cuisine preference, and then based off of the products that we have available and our advice from our community advisory board, we'd formulate different boxes that would be sent out to customers and have recipe ideas based off of the foods in those boxes.
Great. And I think you had a slide where the price point was about 50% of the average competition. And as you become successful in this launch, how do you think about price pressure coming in from other players in the space?
Yeah, we definitely see price pressure, but given the size of the SNAP market, it's enormous, $107 billion in benefits, and we're just aiming to even capture a small piece of that, which equates to almost $1 billion. annually. So we think we can really kind of push back against some of that price pressure because of our focus on both financial and social outcomes, and because of just the sheer scalability of the number of meals we'll be able to provide. At the end of the 6-year period, we're estimating we can provide almost 350 million meals. And so that scalability aspect, I think, allows us to keep our prices low.
Great job, everyone. Just wanted to ask a little bit about the assumptions that you made around fulfillment and the value prop around simplified delivery. How are you thinking about that relative to the competition? Maybe a little bit more detail on that.
Okay. Yeah, so the basic assumptions we're making is that an individual would just only have at home access to oil, salt, and pepper. Those are all the food items they would need. We would provide everything else in the box, and then we are making the basic assumption that they do have access to a refrigerator, and these are the same common assumptions that our competitors and other meal kit delivery industries are making. And then as far as that, we are following a pretty similar model of deliveries right to the doorstep. Yeah, does that answer your question?
Yeah.
Okay.
Yeah.
All right, we are at time. Thank you very much. Great job. And we're going to go ahead and transition to our final team for the graduate track.
Hi, my name is Joshua Rogers, and it's a privilege to be presenting to you today with my esteemed colleagues, Dr. Nell and Michael Rahani. Despite the increase in mental health awareness,
I love that we started with tech issues and we're presenting I promise this is not the system we'll be using. So presenting with Josh Rogers and Michael Rahani, and we're going to be talking about a really critical issue facing our entire community, not just teens, but that's what we're targeting today. So looking at rising depression and anxiety, insufficient access and affordability, this disproportionately impacts underserved communities. And we do have this very real issue of tech usage and information overload, and that disproportionate issue of the stigma around mental health. So when we look at these alarming statistics, we have just over 20% of teens have experienced some type of depression and anxiety. 42% have experienced a major depressive episode, and then 60% have experienced cyberbullying. Another statistic that is a bit controversial but we'll be leveraging for our solution here is that 96% of teens, regardless of socioeconomic status or location, have access to smartphones. So our solution is a smartphone application housing mental health resources, and these will be bridge resources that is very inclusive in nature when it comes to content, and we'll be talking about how we are going to make this extremely affordable for the end user, but profitable for private equity. Why is this bold? We've heard of smart apps before. We know that there is an issue with mental health. A lot of the solutions that currently exist have to do with a Band-Aid approach, or limiting screen usage, limiting access to social media. While some of these measures are necessary and critical, unfortunately technology is part of our present and future. So as we look to a sustainable solution, we need to think about incorporating technology into that solution. This will be a teen-centric design. We'll have privacy measures in place, so a lot of educational content on platform with bridges to link to mental health providers off platform to help address some of those HIPAA compliance issues. As far as feasibility goes, my goodness, this is talked about all over when it comes to public policy, looking for solutions to these issues. There's a lot of scalability here, so from a market readiness perspective, this is already happening. Google just had a commercial come out less than 2 months ago, and they are pledging $20 million to support companies just like ours who are addressing mental health issues and ethical use of technology for teens. When we look at the investment landscape from a private equity perspective, it's very interesting. In 2023, health tech valuations were a little bit lower, so that provides really exciting opportunity for growth. And as far as evidence goes, we've talked a lot about telehealth today. We know that there is good efficacy there, really positive outcomes, and this is certainly a community need. We'll talk about partnerships because even though there are some challenges there, there's also great opportunity to lower costs by leveraging partnerships and having great content as well. Pass it over to Michael to discuss these partnerships and exciting revenue streams.
All right, thanks, Nell. So you've heard about the problem, you've heard about our proposed solution. Now let's talk about how we'll market this for revenue. So first and foremost, the most important thing to us is the content and the awareness. So partnering with schools, nonprofits, and local associations to make sure that the content is relevant but also inclusive. And you've heard Nell talk about how 96% of teens have access to smartphones, but schools are also offering most children tablets and laptops. So that's where we're going to leverage them to help us make that bridge to the consumer. Access to resources, so state and local grants. This money is already reserved for initiatives just like this. And as Nell mentioned, teen mental health is at the forefront of focus right now. Investors, health plans, social media platforms. So you heard Nell say social media companies are making a strict focus on this. The stigma is everybody's on their phone. How many times have you heard that you wake up, you go straight to your phone, you write to social media, right? It's not about limiting that, it's about using it properly. And also using those platforms to help. Health providers, this widens their network. So not only are they getting access to their local people, anybody through regular telehealth, but now you're accessing a broader platform of teens, and we'll talk about some of the challenges with that later. But also the end users, the consumers. So there'll be paid access, paid content within the app as well. So now let's talk about how we go to business. So timeline and metrics. So for our launch, we're factoring about 3 to 6 months for a minimum viable product to start beta testing. We're looking at about 5,000 users for that test, and we want a 30% retention. We're also going to establish something called a baseline health assessment. This is important later when we get to the last step. Our partnerships, 6 to 12 months to establish our key partnerships from the start. So 5 educational institutions are what we're looking for. Those are individual institutions. 2 individual mental health organizations. Then within year 2, we'll look at growth. We're targeting 25% year over year and 50% content interaction every 6 months. For our scaling in years 3 and 4, we're looking at 5 state school systems fully integrated. Not individual schools, but the entire system. And then 5 new features or major updates to the platform. And then at the 5-year mark, we're targeting to have engaged and impacted over 1 million teens with an 80% user satisfaction. Now we mentioned the baseline health assessment earlier. This is where we'll come back and also target how we have improved mental health for each of those users based on their initial baseline.
So you'll notice that a lot of those metrics were very conservative. We did a lot of benchmarking. Our founders have history in working with health tech and school partnerships. We wanted to keep it very conservative and still show that there could be dramatic impact in this space. So of course, financial, we're talking about private equity investment. We feel confident that this will be profitable, but at the same time, where is that money going and how can we lower those costs? So with some of the partnerships that Michael was mentioning, we're looking into applying for programs like with Code Launch. They build out your tech for free. So a lot of times that heavy lift on the front end can be decreased quite a bit. Looking at our health access as well. So it's one thing to say this is profitable, but if we're looking to actually make impact with health, looking at that baseline health assessment, making sure that we're actually making measurable impact when it comes to what we set out to do, and of course inclusion. Because when we're talking about the partnerships that we bring in and the content that's brought onto the platform, that needs to be inclusive content. So we see a lot of awareness around mental health in those more affluent communities that Josh was speaking to, but if we aren't reaching the end user that we want to reach, and if that net promoter score, if that satisfaction rating is not high because that content doesn't feel meaning and relevant to them, we're not doing our job. So those are the areas we're going to look at as far as impact. And really an important part of this is our team. So we all have experience in areas that will be critical to not only the launch but the growth of this product. So healthcare experience, Josh has experience with capital raise, with working with school partnerships and tech solutions, specifically applications. Michael has that expertise as well as strategy. And I have healthcare entrepreneurship, lowering costs with PR, proper biz dev, and working with nonprofits specifically. So we're so excited to intro Echo to you. We want to amplify voices, empower resilience, and make that one Echo many.
Thank you for your presentation this afternoon. Quick question for you. You mentioned that the design is teen-centric, and just wondered how you plan on capturing their voice in your design.
So we think that's a delicate balance. We are leveraging more strategic partners that will already have content. So that helps with increasing the credibility and offsetting some of that cost of that initial build to bring content onto the platform. We want to make it really easy. So with search functions, if someone's having an issue with cyberbullying or something specific that a teen might be searching for, like I said, on our team, we have a founder who's worked specifically with the younger demographic when it comes to technology and making sure that that's user-friendly. And we plan to leverage that expertise as well.
One more thing to add to that, the critical focus for us was the stigma, right? It's difficult for children in any community of any age to bring up to their friends, to their school, to their parents, hey, I have an issue and I'd like to get help for this. So the app itself is designed to be private enough for them to get initial resources to help them overcome that stigma and start opening that up and breaking that barrier down. So for us, that was how they first get heard in this.
Thank you. And maybe just building on that then, Michael, and it kind of ties to Kimberly's question. So I love how you talked about, everybody uses their phone. We're not going to, this is meant to lean into that, but also, teens like to share, right? Like to feel connected. So, and maybe you were getting to that a little bit in the inclusion point, but I'm just kind of curious, maybe take your statement you just made, Michael, a little bit further. How will this get to community and empathy and connectedness? Because I thought I heard that in there, and I would think that's important to teens.
Yeah, so we want to make it the new normal, right? So TikTok dances are all the craze, and people, if you would have asked me when I was a teen, hey, will you dance in the grocery store? I would have been like, absolutely not. My parents will hit me with the cart or something, right? But it's the new normal. So our intent is to make this comfortable and normal. So give them the resources to get to the actual content on the platform where experts are talking about this and saying, hey, you're not the only one going through this. Everybody's going through it, right? It takes you back to that feeling we had growing up where you find that friend that you connected with that, hey, my dog passed away, yours did too, and now you have that connection and you're able to talk. So when you open this up on a tech platform and make this normal for them, yet still private enough that they don't have to tell who they are unless they wanted to, there's a community within that app that they can access that. Great question.
We have time for one more question.
I think mine will be pretty quick, but how do you all envision driving engagement with the app itself? Obviously, you're not only competing with other apps that are similar, but any app that's on the smartphone is going to be competing for time with your resource. How do you get people in the door, even if it's already downloaded from their app store?
Yeah, it was sorry, I'm just jumping in. It was the first question we asked ourselves when we put this together, right? And that's where the schools came into play. So I'll tell you a story. My nephew, throughout COVID, became better at technology than I did, and he was 5 years old, and I was blown away by that. I mean, to the point where he could trick us into thinking he was on breaks when he should have been in virtual class. But it was because the schools were giving them that technology, and they were teaching them how to use it and how to access things that it took us to our adult years to figure out. So as far as getting them engaged, we start early with the school hardware, and there'll be ways within the app, we couldn't get into that with the presentation, but the engagement will be there, starting with that baseline assessment to the point where we're collecting data on their mental status and how they're feeling, but also it's imperative for us to get that so that we have the red flags and the trigger mechanisms on the back end to alert school officials and parents if we do feel there is a concern that we need to get further help for.
And just to add to that, we feel confident with connections of not only our founder team, but connections here at Notre Dame for leveraging those resources to get into schools. But why the school, the association, the nonprofit piece was also very interesting to us was it's more of a B2B approach. So it's more stable. So the capital raise needed or the marketing collateral needed to just directly penetrate direct to consumer is a lot different
Very good. Thank you
All right.
so
Thank
much.
you,
Round of
guys.
applause for our last graduate team and all of our finalists. Thank you. Thank you, thank you. Go ahead and take that. So we're going to take a moment for our judges to deliberate. So I'm going to invite all of our judges to join Kristen out in the hallway, and you'll go to a room to deliberate. And then in the meantime, we'll go ahead and give them a moment to depart. Everybody else to come on in. I think they're going to join you. And I would like, though, I think I saw him in here. Right next to me. Sorry, I saw you in the back before I was looking. So while they're deliberating, I would like to introduce one of our undergraduate students, Mateo Acosta, who is going to introduce our keynote speaker. A little bit about Mateo, though, before he introduces the speaker. He is a current student at the University of Notre Dame, double majoring in finance and economics. He's also a member of our varsity soccer team. And he and his teammate, Cleveland Sellers IV, were our first place, thank you very much, were our first place winners in the 2023 D&I Grow the Good in Business case competition. So congratulations for that last year. And also, I'm pleased to share for our KPMG folks who are here, he will be working at KPMG this summer in their Economic Valuation Services group at the Chicago office. So I'm going to go ahead and pass it over to Mateo. Thank you.
Hello, everyone. That was really nice and the first time that's ever happened, so thank you. So I'm pleased to welcome Claudia Saran to the Mendoza College of Business. Claudia is a highly accomplished and recognized leader in the field of industrial manufacturing. With over 25 years of experience, she currently serves as the U.S. sector leader at KPMG and is also a board member of the National Association of Manufacturers. Claudia's deep interest and passion for the evolution of industrial manufacturing has guided her throughout her career, as she works with leaders of automotive/mobility, aerospace and defense, and diversified industrial companies to drive change agendas and navigate their complex industry challenges. As the U.S. sector leader at KPMG, Claudia brings practical client engagement experience in areas such as organizational culture transformation, functional performance improvement, growth strategy activation, and leadership team alignment. She is committed to ensuring clients have the best experience with KPMG in terms of capabilities, quality, and overall satisfaction. Claudia's educational background includes an MBA from Northwestern University's Kellogg School of Management and a bachelor's degree from the University of Illinois, Urbana-Champaign. Outside of her professional achievements, Claudia is a mother to 5- and 3-year-old boys. Let's give a warm Notre Dame welcome to Claudia Saran.
Thanks so much. Sorry, the control freak in me wanted to make sure all of my judge comments got to my colleague there, so that's why I was just briefing with Dinesh before he walked out. I've got a few minutes with you all, and I don't know most of you in this room. And hopefully you guys are all like relaxed after having presented, right? I was like, wow, once you get that done, just a big, big relief. So I tried to throw some things together to just maybe give a little bit of background, but thank you for that, Mateo. Makes me sound old. I guess I am. I've done a lot. But I'm a Midwestern girl with a very global professional experience over the last almost 35 years of my career. From the west side of Chicago, went to Trinity High School, which is an all-girls Catholic school in the western suburbs, and then as Mateo mentioned, University of Illinois, finance major. Cost accounting was scary to me, so I stuck my toe in it a couple times and said, let me just stick with finance. And then about 10 years in, I went to Northwestern for my MBA. I was born and raised in Arthur Andersen, so the Big Four used to be the Big Eight. And that's kind of when I went right out of undergrad, 21 years old. I said, send me anywhere. And they did. So all those places you see on the bottom were long-term work and living assignments for me. So we had a joint venture in Port Louis, which is the capital of Mauritius. So I worked with a company, Duchesal Dumais, there for a couple years to help them set up was really kind of a supply chain consulting practice, which was an area I was starting to get into. You see Buenos Aires, you see Hong Kong, companies like Commodore Computer, really aging myself, where we did activity-based costing work. There you have Amsterdam, one of my favorites. I spent a lot of time in the Netherlands and our Nordic region, again, helping them build out their consulting businesses. As Mateo mentioned, so the last 3 years I have been corralling all things industrial manufacturing for KPMG, so our audit, tax, and advisory capabilities. I grew up in advisory, but I love all three of those businesses the same. That's a plant floor of my beloved client, Volkswagen. So it's nice to put heels on and a dress. A lot of times I have steel-toe shoes and hard hats and earplugs, so it's nice to come kind of big girl today to talk with you. But so happy to answer any questions about that industry. It's automotive, aerospace, and defense, and what we call conglomerates. So the General Electrics, Honeywells, Johnson Controls of the world. Hugely interesting space, not particularly female dominated, so it's fun to navigate, and when that kind of gets me a little bit into DEI, which we'll talk about. I'm the youngest of 7, so somewhere up there you see me and my brothers and sisters. So my parents, who were married for over 60 years, had 6 kids in 6 years, and I came about 10 years after. So it's basically like growing up with 4 sets of parents. Lots of life visions that they shared with me. I worked and lived all over the world for a good couple decades, so I'm a late bloomer, probably socially. I was kissed a good number of frogs in my dating life, I guess you could say, before I met my prince of sorts. He'd probably be blushing if he heard me say that, but didn't get married till very late in life and had 2 very, very geriatric pregnancies, as they love to call it. It's such a terrible term. At 49 and 51, you can see me there pregnant with Zach at 51. And I'd like to highlight that, like when I was formerly our vice chair of culture, which was an interesting assignment to sort of do what I do with our clients, with our firm. But then I pretty quickly introduced myself as a mom, because I'm sleep deprived. There's a whole lot about my boys that kind of impacts who I am today. Then I became our advisory industry leader. The guys were growing up there, and then here you see me today. This was speaking to a group of female executives in automotive, but they're really calling themselves mobility companies, so I wanted to show them how mobile my guys were. So there they are. So they're growing up. And I know the thesis for today was, how do we think about DE&I in the workplace? And, it's, to me, there's kind of a blurred line between your personal and your professional life. Like, I looked at this, I'm like, okay, that's a lot of words about DEI. I looked at our values, which I love. There are a lot of words. I looked at your guiding principles, which I love. Like, but a lot of words in all of this, right? When we think about how do we bring who we are into different environments, our personal life, our professional life, I like things pretty simple. And so I was thinking about where you all are in your personal and professional and academic lives, and if anything, just to kind of share some of my experiences. And it really kind of came down to these 3. I started with a longer list, but they kind of jumped into these 4 kind of different categories, I guess. When you're interacting with people, you're going to be working in teams your whole life, right? There's very few things we do where you get to do it solo. For those of you in the graduate program, I know when I was going to get my master's, we were tied at the hip with our study group. We had that same group over a couple years. One of my study group partners is an actuary. And so what I loved, every class we took, Blake would reduce it to a formula. And it was the coolest thing to see his thought process. And it wasn't just statistics, right? It was marketing, it was economics, it was data and analytics. Everything concepts we talked about, he could somehow, and actually felt most comfortable putting those things into a formula, and he would like unpack it for us in our study groups. To me, that's a great example of DEI, right? Where you sort of embrace how you see things, but you still can connect on those same topics. So in my mind, again, I'll go back to kind of these lessons, but I think a lot of you find yourself in team environments, working with different perspectives. Here's just a couple words to live by. One is be present, and that's super, super obvious, but really difficult. All of these presentations talked about things like social media, how much is facing us, how cluttered all of our minds are. I'm probably infamous in our teams for this phrase. When I'm talking with someone, either face-to-face, phone call, Teams call, Zoom call, you name it, and I sense they're not paying attention, I'll interject and I'll say, you know what, Mateo, if this isn't a good time for you, we can reschedule. Which is my sort of nice way of saying, you're not paying attention and you're wasting both of our times, right? And 9 times out of 10, it's actually a little bit of cold water on that person. They say, oh, no, Claude, this is a good time. We can, and they focus. So I'm trying to tactfully remind them to be present. It's really obvious, but it's really hard to do, right? And the more you can pull yourself in to say, okay, I've got a lot of other crap going on, but this is a 30-minute conversation that's really important to this individual, and especially as you progress in organizations, people are coming to you with problems. People are coming to you because they need your counsel. The last thing you want to do is appear to and actually be distracted. So you've got to kind of build that discipline to stay focused and be present. Being humble doesn't mean lack self-confidence, don't be proud of who you are, what you know, what you've accomplished, but everybody can teach you something. On my travels, one of the nice things is I've been so many places for so many years. I've got friends in the Detroit rental car company. He and I debate the Bears and the Lions all the time, right? I've got my Caesar salad guy in the Philly airport, right? And we have the things that we talk about. Everybody's got life experiences. You can learn things. And frankly, it just makes life a lot more enjoyable if you're open to hearing about what other people think and what other people know. It's kind of boring if you just sort of lock in and say, I've got this, and you don't take a whole lot in. But you got to catch yourself, because sometimes you'll get in that mode and you haven't picked up anything. You haven't actually stopped and been interested in somebody's story in a day, in a week, maybe even a couple months. It's almost like you get in kind of a funk with that. So make sure you're staying humble and wanting to learn about people. Which leads me to this third point, and I think I'm probably speaking to the choir here, but you just have to be interested in things, right? You want to learn, ask questions, get good at listening and asking questions, asking for examples, asking for how people feel about that. If you go into a conversation, especially with clients, and think they're just going to disclose their deepest problems and concerns on that first meeting, that doesn't happen. You've got to credentialize yourself, but you've got to be so attuned to what they do start to disclose, and you've got to build on that. And that's on you to build that conversation. But it ties to those others as well. Because if you weren't listening, how many times does someone introduce themselves to you, and 2 seconds later you're like, shoot, I forgot their name. Okay, and you know what? And I've just gotten really good at, I'm sorry, can you tell me your name again? Right? Because there's so much going on up here. There's so much clutter, but that's an important thing, and you don't always get the benefit of a big name tag in front of that person. So there's no harm in saying, I'm sorry, can I catch your name again? I just did that to John back there because I thought it was Matt. And I said, is it Matt? And he said, no, John. Okay, all right, my bad. I do that with my brothers and sisters too, because I got 6 of them. So a lot of times I'll run through all 3 sisters before I get to the right one. And then lastly, and hopefully this is super common sense, but again, in the hustle bustle of our calendars, reach out to people and be kind. I don't know how many hundreds of emails I get in a day. If someone throws me a bone of, hey, I just read this piece you did, and it, found it really intriguing for X, or, thank you for talking to my mentee, right? That like, if I get a compliment or a thank you, the reverb on that email for me, like I can get energized for like the next 8 hours of my day off that one message. The thing I try and do is every day I pick somebody to ping, text, I'm a big texter, I text, email, something, to just say something nice to. And it's real easy to do, right? There's always things you admire in people, there's information that comes your way about somebody. But think about that, like just take a second to text somebody and say, great job on this, or really interesting, or this caught my eye. It's just, you build such a nice vibe around you. And again, all of these things, as you progress in whatever career paths you want to go down, you want people to want to work with you. And I think some of everybody's technically deep, right? In a university like this, data and analytics, right? We look at all these different majors, mathematics, finance, accounting. But bringing these qualities of yourself is a differentiator. It's sure a differentiator for employers. If you're in a client service business like ours, super important. And again, whatever you're working in, whatever the industry, whatever the organization, yes, we've got plenty of robotics and Gen AI that's coming in, but guess what? You're still going to be dealing with people. We're not going to shake loose working with colleagues and team members, people who work for you, people who you work with, your bosses. So just wanted to reiterate to keeping these things in mind. I'll go back. So I've got 35 years of work experience, not too many years being a parent, but a whole path in front of me. A few years being a wife, lots of years as a sister, as a daughter. And again, I really think technical competence, it's fun to build it. You can build it your entire life. There's still so much I'm learning. Again, this foray into industrial manufacturing for me is opening up all sorts of different intellectual avenues. But working on those sort of human being skills, the being connected, being present, being humble, being kind, I think it'll help you get so much more happiness out of all of those roles. So just wanted to punctuate that all for you today. Fabulous job. I loved the diversity of the problems you all tried to solve and then the solutions that you went after. Like I just kind of marveled at the breadth of that. So congratulations on being done with that, having put that together. Team presentations, 8 minutes. I don't know how you all did that. That's super tough because that requires a lot of prep. Great job in Q&A, which is much more difficult, right? Because you can even almost feel it in your body when you shift from presentation to, oh crap, what are we going to get from these folks, right? I had a partner who I worked with for a number of years down in Argentina. I was like 22. He was 62. He was my mentor's mentor. My partner in Chicago, who'd grown up in Argentina, kind of sent me down there, said work with them for a while. And he was a master at Q&A. What he would do is take in a question, so actively listen to it, pick it apart to say, okay, I heard 2 or 3 things in your question. Usually he'd try and move a little closer, so if you had a name tag, I could address your name to say, okay, Bob, here's what I heard. If it was sort of a tough question, a bit with a little bit of an edge, right, he'd usually try and take that edge off by saying, okay, well, Mateo, tell me what you really think, right? Because if he led with a little bit of a poke or a jab, and then he just would masterfully answer all of those questions, right? He'd go through to say, here's the 3 things that I heard. But I could see him taking a few seconds of silence to compose his thought. But you guys did a great job with that. We had some deliberately tough questions, and I could see the physical and mental, like, okay, let me work on this, and let me try and crush it. And I think you all did an awesome job crushing the Q&A. So thanks for having me today. Thanks for letting me talk a little bit about my background and really my 2 cents. I had a lot to say about all of these, but I think this is really what it all gets summed up to. So I wish you all the best of luck. I'll be here to hang out in the atrium too. So congratulations to all of you. Thanks so much.
Thank you, Claudia. So Laura, is Laura back there? Are they still deliberating? Could you look real quick? I want to see if they're still in there. And I loved the message, Claudia, that you shared about I'm going by memory, being interested, being present, being humble, and being kind. I think that that's something that we should all strive to live by. So thank you. I appreciate that. So we may take a minute break. I want to see if it looks as if they're still deliberating, and if so, we'll give you a 5-minute break. But if they are back, we would like Kristen to announce who our winning teams are. So we'll wait just a moment. In the meantime, I'm going to cue up the next slide. Wonderful. Well, welcome back to our judges. And I will welcome Kristen up to the front in just a moment. All right, I'm going to hand it over to Kristen. Yes, I'm going to move that table really quick, though. Okay.
All right, the judges have completed their deliberation. Now's the moment we've all been waiting for. So it's now time to announce the winners of the 2024 DE&I Grow the Good in Business case competition. As I announce your team, I ask the students to come to the front of the room, receive your amazing Notre Dame swag as your award, and of course, be celebrated. We'll start with the undergraduate teams. In 3rd place, Team RAAM. Come on up. Congratulations. You can, go ahead and take on a seat or stand up here, please, and we'll get some photos, of course. In 2nd place, Team EcoHealth. Come on up. Congratulations. Yeah, and then go ahead and join your colleagues there. And that means in first place, we have Team MaternaLink. Come on up, congratulations. Thank you, congratulations. Yeah, go ahead and join. And then I'll ask our undergraduates to stay here, and our graduate teams will join them as well. For the graduate teams in 3rd place, Team EquityCare. Come on up, congratulations. We can bring you yours if you like.
I'll bring it. You want me to carry you up?
I'm a professor. So. Congratulations. Yeah. All right, in 2nd place, Team Shirish. Come on up. Congratulations. Congratulations, guys. And that means 1st place is Team Easy Plate. Congratulations. right, let's give our teams another round of applause for their awesome work today. So proud of all of you guys. To be to stay here a minute, we'll take a picture, but I wanted to just finish up here. So to bring our event formally to a close, I wanted to reiterate the gratitude that Dean Cremers expressed earlier today to our corporate and strategic sponsors. Your investment in this competition and our students is a true testament to your commitment to creating a better workplace for everyone. To our keynote speaker, you've challenged us to make a commitment to DE&I beyond this competition and to integrate this commitment into our personal and professional lives. Thank you. To our judges, including the faculty, staff, and alumni who judged in the first round, and the distinguished panel of leaders who are here today, we are grateful for your time, feedback, and expertise. And to the Mendoza faculty and staff, thank you for working tirelessly to support our students and this event. And I personally want to thank Stephanie, Laura, and Heather Graham, who went above and beyond to elevate this experience. And then finally, to all of you, our participants, your thought, creativity, and business acumen that you put into this case truly exemplifies Mendoza's mission to be a force for good in society. And thank you for your efforts and your inspiring work. And as we celebrate the culmination of this competition, let us remember that our work is not done. Promoting diversity, equity, and inclusion is an ongoing effort that requires us to remain vigilant and proactive in our efforts to create a more inclusive and equitable